Barcelona in Spain and member of the Education Committee of GRAPA. It is my great pleasure to welcome you to the GRAPA Spartan Educational Symposium. My co-facilitator, Professor Jörg Ehrman, who is Assistant Professor of Medicine at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts, will be presenting this session. It is to be held, this is the second session of this fourth installment, which is more convenient for European and Asian time zones. We will cover comorbidities in psoriasis, psoriatic arthritis, and spondyloarthropathies. And the program will start with a presentation of the patient's perspective by our patient research partners, Arnon Katz from Israel and Dennis O'Sullivan from Ireland. Dennis will be in the panel discussion too. Then we will present. We have some pre-test questions or some questions prior to the presentations on cardiovascular comorbidities in psoriasis by Wolfgang Benck. He's a professor of dermatology at the University of Geneva, by Professor Lei Shan Tam. She's a professor at the Hong Kong University, Chinese University of Hong Kong, and she will speak on psoriatic arthritis. And also Professor Lian Gensler from San Francisco, who will talk about the cardiovascular comorbidities of axial spondyloarthritis. Then we will move with some intervening questions to uveitis. Professor James Rosenbaum will be presenting the topic of uveitis in spondyloarthritis. Professor Rosenbaum is Chief of Division of Arthritis and Rheumatic Diseases and Professor of Ophthalmology, Medicine and Cell Biology at Oregon Health and Science University at Portland, Oregon, United States of America. And then we'll, with some preliminary question, we will proceed to the gut microbiome discussion in psoriasis and psoriatic arthritis by Professor Diamond Tachi. Diamond Tachi is a professor and head of the Comprehensive Center for Inflammation Medicine at the University of Lübeck in Lübeck, Germany, Schleswig-Holstein. And after that, we will have some responses to the questions by Professor Jörg Ehrman and some discussion. And we start a panel discussion with panelists Dennis O'Sullivan, Diamond Tachi, Lei Shan Tam, and also Sergio Schwarzman, who is a clinical associate professor of medicine at Weill Cornell Medical Center in New York, United States. With no more ado, we will go on with the presentation of our patient research partners. And these are our faculty disclosures. Thank you.
Comorbidities and burden to patients in PSA. Hello, my name is Dennis. I'm from Ireland. Diagnosed with PSA in 1999.
Hi, I'm Arnon from Israel, diagnosed with PSA since 2002. From my experience and from other patients, I learned that PSA has many accompanying related conditions and side effects.
I have the same impression from PRPs I have spoken to about issues relating to the disease and the medications.
Many physicians mentioned possible complications of the disease, such as cardiovascular problems, uveitis, and gut microbiome. Yet, patients are worried by additional issues, for example, reflux, possibly caused by the medications themselves.
Patients experience problems such as colds, skin irritations, and infections more easily, and are slower to recover. We feel medications required may worsen our overall health.
Issues related to the gastrointestinal system, obesity, inflammatory bowel disease, symptoms such as heartburn and digestion, bloating, constipation, and prolonged coughing. All these need additional medications, and they can possibly interact with PSA itself and its medications.
Fatigue and sleep worries, constant high-level fatigue, getting tired easily, and fear from the extreme impact of sleep issues on health mood, relations, and resilience.
A real up-to-date concern is related to the possible interaction between PSA and COVID-19. Should we take the vaccine? What are the possible effects of taking it? Does the type of vaccine taken influence differently our treatments for PSA? And with our compromised autoimmune system, will there be a need for any additional special care or treatment?
Patients are worried that their doctors do not pay enough attention to psychological issues. Patients refer to issues such as depression, nervousness, anxiety, unstable moods, and guilt due to their offspring inheriting the disease. Actions that patients would appreciate from their doctors.
Doctors, explain to the patients what to expect about PSA and its comorbidities and what to look out for. Patients need to understand what problems are and are not due to the PSA or its medications. Tell them about useful websites or other resources of information.
Improve screening and patient awareness of broader comorbidity issues, e.g., waiting room completion of problems such as PSA-12 or pre-appointment questionnaires.
Patient worries. Possible interactions between PSA, comorbidities, and the medications, and long-range effects, including, for example, higher risk for cancer and heart problems of the medications, for example, from the biological medications.
Doctors, encourage and make it easier for patients to talk to you. Be aware of patient life impacts, such as inability to work or engage in leisure or social activities. Be prepared for wide-ranging questions, e.g., can sleep issues such as sleep apnea be connected to PSA? What should patients consider when planning a family? How should we monitor for offspring's potential to inherit our disease? To conclude,
Patients experience problems and they seek their doctor's help for these. They may not know which problem is due to the disease itself or to any related conditions or due to the medications or any other problems.
please be aware that PSA and its related conditions may impact on all areas of the patient's life. The complete effect of the quality of the life of the patient should be considered, and not only dealing with the pure medical situation of PSA.
We thank you all for listening to our perspective and please consider what you heard.
Thank you, Dennis and Arnon. And here's our first pre-test question. Which of the following statements about cardiovascular disease in patients with psoriasis and psoriatic arthritis is correct? Genome-wide associations have shown that psoriasis and psoriatic arthritis share multiple risk loci with metabolic syndrome and coronary artery disease. Increased insulin sensitivity of vascular endothelial cells may contribute to cardiovascular disease risk in patients with psoriatic disease. The Framingham risk score underestimates the risk for cardiovascular disease in patients with psoriatic arthritis. Or EULAR recommends cardiovascular disease risk assessment for patients with inflammatory rheumatic diseases, including PSA, at diagnosis and every 10 years. Please select the best answer by clicking into the box at the screen. And we give you 5 more seconds to answer. 5, 4, 3, 2, 1. Okay, let's go through pretest question number 2. Aortic valve disease and conduction defects are well-recognized complications of ankylosing spondylitis. What is the most appropriate approach to screen patients with axSpA or AS for these conditions using transthoracic echocardiogram and electrocardiogram? Screen all axSpA AS patients after 10 years of disease. Screen all axSpA and AS patients who have more than 2 cardiovascular disease risk factors. Screen all AS patients, so only the AS patients, who have had more than 5 years of disease without being on biologic therapy, or mandatory screening is not recommended. And please select the correct answer. 5, 4, 3, 2, 1. Okay, and I think with that, I hand it over to Dr. Puch for introducing the next speakers.
Hello, everybody. My name is Henning Böhnke, and I'm excited to be part of the GRAPPA Spartan Global Education Virtual Seminar Series 2021. My topic is psoriasis and cardiovascular comorbidities. We'll briefly describe the problem based on immunological data, and then discuss causes of this issue at the level of genetics and pathophysiology, and finally, of course, address clinical consequences in this context. Now, this paper from 1995 already describes a number of what we call today comorbidities. It talks about diabetes, heart disease, etc. And we do know by now that there is a number of comorbidities in psoriasis patients. Here, a list of what I would consider the canonical comorbidities of that disease. All of them are really established now at the level of systemic literature reviews or meta-analysis to be associated with psoriasis. And noteworthy, the metabolic syndrome or parts thereof are associated with psoriasis. Now, the question is, of course, why that is the case, and the potential explanation could be shared genetics. So there is data that suggests that there is a shared genetic control of psoriasis and some comorbidities. This meta-analysis here looked at a number of genome-wide association studies and found shared loci for psoriasis and Crohn's disease. And I find this publication particularly interesting because it describes an insulin-responsive enzyme with a mutation that could actually link psoriasis to hypertension, and namely diabetes. However, we had a thorough investigation of the whole catalog of genome-wide association studies that has so far been published, and could not find any link between psoriasis and the genetics of these comorbidities. However, as a control, if you want, we did see in this analysis shared loci between the metabolic syndrome and coronary heart disease. So our conclusion from this analysis is that shared genetics cannot explain what we see clinically. Now, what we do see clinically is a solid dose effect, in the sense that severe psoriasis, shown here, but not mild psoriasis, is associated with an increased risk of cardiovascular disease, as shown by Joel Gelfond's famous study that was a population-based study. In parallel, Ralf Ludwig, in a case control study, looked at coronary artery calcification, and that allowed the conclusion that psoriasis should be considered an independent cardiovascular risk factor. And if you look at all the publications throughout the last 15 years or so, we come to the conclusion that mild psoriasis is not associated with a higher cardiovascular risk, whereas moderate to severe psoriasis shows this effect. Now, is this reasonable? Do we have a good explanation for that? Pathophysiology helps us to understand that this actually may be real. In order to understand that, we have to know that the insulin receptor is expressed on the vast majority of cells in our body, not just metabolically active cells such as musculoskeletal cells, but also endothelial cells. And once insulin binds to its receptor, it kicks off two signal transduction cascades. One that at the level of endothelium is protective, anti-atherogenic if you want, and another cascade that actually results in pro-atherogenic effects. And the key information on this slide is that once there is inflammation at this level of this kinase here, the signal transduction cascades towards the protective effects is shut down, and all that remains is the cascade towards the pro-artrogenic effects, as I'm going to show you in the next slide. So you will see the generation of an inflammatory milieu in human endothelial cells and the inactivation of this cascade here. So this is PKB, and we are looking at the phosphorylation of this kinase, so activation after binding of insulin to its receptor. And you see that in these human dermal blood endothelial cells, insulin usually activates the kinase, whereas this effect is blocked in the presence of a cocktail of pro-inflammatory cytokines, thoracic cytokines, including IL-23, TNF, etc. And when we quantify it, we see a solid effect. Now, this was the key stone for the concept of the thoracic march, which is a concept that is readily accepted in the world of diabetology, where obesity is considered a systemic inflammatory condition, which results in insulin resistance, which at the level of the endothelial cells causes a dysfunction, stiffness, which is the basis for atherosclerosis, and finally causes myocardial infarction, or at the level of the brain, stroke. And Dee and others have shown that every step of this cascade can also be triggered by psoriasis, which needs to be considered a systemic inflammatory condition. So, preliminary summary on the discussion whether or not psoriasis should be considered an independent cardiovascular risk factor. Epidemiologically, I've shown you the dose effect, whereas it remains true that, of course, many of the cardiovascular risk factors are present in our patients with psoriasis. So the hen and egg question is still somewhat open. Genetically, there are studies that show that the genetic control of psoriasis and its comorbidities can clearly be separated, and others that show that at least at certain levels there seem to be some genetic overlap. Pathophysiologically, namely the phenomenon of insulin resistance is key to psoriasis as well as atherosclerosis, as well as numerous other factors. It has to be acknowledged that we do not understand everything in detail. For example, the role of IL-17A is it pro-arthrogenic, anti-arthrogenic, still is a matter of debate. But what I think we need to stress is that all we see at the level of the skin, including the obvious comorbidities of our patients, is just the tip of the iceberg. And psoriasis really is a systemic inflammatory condition which can be made visible by PET CTs like this one from Nihal Mehta. You see the inflammation at the level of the skin, the joints, the liver, but also the endothelial cells compared to a normal person. So this is the two dimensions of psoriasis explaining the cardiovascular risk of those patients. An interesting question is whether we can reduce the patient's risk through treating the systemic inflammation. Now, 10 years ago, we did such a study looking at the blood flow in the blood vessels. And you see a dose response curve here prior to treatment and 6 months into a systemic treatment for psoriasis. And you see an increase in the blood flow. So we increase the elasticity of the blood vessels. And this is a sign that we reduce the patient's cardiovascular risk. That particular study was done with fumaric acid esters. And 1 year later, another group published a similar study. You see the same effect, this time using the TNF-alpha blocking adalimumab. And more recently, 2 years ago, the KARIMA study was published looking at zicokinumab. And there too, you see an improvement in blood flow under the treatment. So this is a surrogate marker. As of now, we do not have a study on hard endpoints, so mortality. But at least at the level of surrogate markers, we do have the impression that continuous systemic anti-inflammatory therapy for psoriasis tends to reduce the patient's cardiovascular risk based on surrogate markers for that risk. Clinically, it is important to address comorbidities. This paper, almost 10 years old, shows a comprehensive algorithm for the most important comorbidities. So again, obesity, hypertension, dyslipidemia, diabetes, or the metabolic syndrome as large, as well as numerous other ones. And I just want to highlight that as of today, repetitively new and updated recommendations have been published, like this one from the American Academy of Dermatology, in a joint effort with the National Psoriasis Foundation, that stresses, when it comes to cardiovascular risk of the patient, that a risk assessment has to be done in each and every patient with psoriasis, be it mild or moderate or severe. A screening in patients with moderate to severe disease should be done early and more frequently than routinely done. Very important, there are risk score models that help GPs, internists to define treatment goals for hypertension, diabetes control, etc. The respective risks should be multiplied by a factor of 1.5 to address the extra risk that is induced by psoriasis. This is in line with what the rheumatologists say with regard to rheumatoid arthritis. And then, of course, the issues have to be addressed actively, be it by the GP or the dermatologist. So in summary, psoriasis is associated with increased cardiovascular risk. Insulin resistance may contribute to atherosclerosis in these patients. There are still contradictory data on the question of whether anti-inflammatory treatment of psoriasis results truly in a reduced cardiovascular risk. But what is without doubt true is that patients with moderate to severe psoriasis need to be screened early and regularly for their cardiovascular risk profile. Thank you very much.
Lai Shangtan from the Chinese University of Hong Kong. I'd like to discuss with you regarding the risk assessment of cardiovascular comorbidities in patients with psoriatic arthritis. Indeed, circulatory diseases was the leading cause of death in PsA patients, and they have a standardized mortality ratio of 1.3 due to cardiovascular diseases compared to the general population. And in a meta-analysis recruiting more than 30,000 patients have demonstrated that cardiovascular morbidity was increased by 43%. So if we look at the Euler recommendation for cardiovascular risk assessment published a few years ago, cardiovascular risk assessment is recommended for all patients with inflammatory arthritis, including patients with psoriatic arthritis, according to the national guidelines. So let's look at this patient. He's a 45-year-old male with normal lipid profile who's a smoker, no history of diabetes or high blood pressure. So the Framingham risk score was 9.4, which was considered not high. So what would you consider? Well, the problem is Framingham risk score underestimates the true cardiovascular risk profile in newly diagnosed PsA patients. So if we use the 1.5 multiplication factor to compensate for the lack of inclusion of inflammation, these adaptations do not improve discriminatory ability and calibration amongst PsA patients. And all the cardiovascular risk scores also underestimate the risk of subclinical atherosclerosis in PsA. And this modification only improves the sensitivity of the Framingham risk score and the ASCVD risk score to a moderate level. So what else can we consider? Actually, Euler recommends to consider performing high-resolution ultrasound to look for carotid plaque. So on the left-hand side, this is a very nice and smooth carotid artery. And on the right-hand side, you can see a protrusion highlighted by the arrow. This is the atherosclerotic plaque, which indicates an increase in cardiovascular risk. Indeed, we look at 100 patients with PSA followed for 10 years, and the presence of carotid plaque at baseline was associated with a 2 to 3-fold increase in risk of developing cardiovascular event, even after adjusting for disease activity and cardiovascular risk factors. So back to our patient. In view of the presence of subclinical atherosclerosis, high risk of carotid atherosclerosis, we performed a carotid ultrasound for this patient, and indeed we found a carotid plaque. So what would you do in patients with the presence of carotid plaque? Would you start statins or perform a coronary CT angiogram or refer to cardiologist? Well, we've looked at our patients, 90 PSA patients compared to 240 age, sex, and cardiovascular risk factor matched control. We were actually quite surprised to find that 60% of our PSA patients actually harbored a coronary plaque, and the prevalence was doubled compared to the control, signifies that a lot of our PSA patients actually had silent coronary ischemia. So in view of this finding, we did proceed to order a coronary CT angiogram, which surprisingly actually revealed triple vessel disease, and the calcium score was more than 1,000. So he was diagnosed to have ischemic heart disease and referred to a cardiologist. And we started him on aspirin and statin, and the cardiologist performed coronary angiography and PCI on the left anterior descending artery, and he was also treated with clopidogrel for a year. Of course, we cannot overemphasize the benefit of a healthy diet, regular exercise, and smoking cessation for all our patients. And antihypertensives and statins should be considered as similar to the general population, and the prescription of NSAIDs should be with caution, especially in patients with documented cardiovascular disease or in the presence of cardiovascular risk factors. Please do not forget, inflammation was actually driving the premature atherosclerosis. So we followed this patient prospectively according to a special protocol aiming at achieving MDA, and we, after follow them for 2 years, patients who achieved sustained MDA indeed had a reduced risk of subclinical atherosclerosis progression. In summary, ladies and gentlemen, psoriatic arthritis patients are at risk of premature atherosclerosis because of the systemic interacting with the metabolic risk factors. So in patients with doubt, we can consider imaging study to help us for the cardiovascular risk assessment. Effective suppression of inflammation and treatment of cardiovascular risk factors may prevent progression of subclinical atherosclerosis and cardiovascular events. Thank you very much for your attention.
I'm Leanne Gensler. I'm now going to present the risk assessment of cardiovascular comorbidities in axial spondyloarthritis. I framed this as thinking about the risk factors, disease, and mortality in axial spondyloarthritis, and then thinking about other manifestations and the role of medications on both the outcome of cardiovascular disease and the related risk factors. So first, thinking about the risk factors and understanding this relationship between the risk factors, the disease, and then medications and their impact perhaps directly on cardiovascular disease or indirectly on inflammation, which then affects cardiovascular disease. A recent meta-analysis looked at these cardiovascular risk factors in a pooled number of studies and showed far and away the most common cardiovascular risk factor is hypertension, as you might expect, affecting approximately 23% of patients with axial spondyloarthritis. But other cardiovascular risk factors are also common, and thinking about them as we think about treating our patients is very important. If you look at these risk factors in comparison to control populations, you see that the pooled odds is significantly higher in axial spondyloarthritis. However, beyond coronary artery disease, which is the most common manifestation, we should also think about valvular disease and conduction disease in axial spondyloarthritis. And I'll talk about a little bit about those and how to risk stratify for those patients. Now, thinking about the prevalence of the manifestations, not the risk factors in axial spondyloarthritis, from the same meta-analysis in 120,000 patients, you can see that the most common cardiovascular manifestation is ischemic heart disease, but other manifestations do occur, and the question is, do these occur at a higher rate or more frequently than they would occur in non-axial spondyloarthritis controls? So addressing that with a meta-analysis, this is the most recent one, looking at cardiovascular events, including MI and stroke, showing that ankylosing spondylitis patients in these studies had a higher odds of both myocardial infarction and stroke, with an odds of 1.6 and 1.5 respectively. Now, sometimes we think about, is this the disease that is a higher risk? In other words, we definitely associate rheumatoid arthritis with cardiovascular events, and is it different in spondyloarthritis? So addressing that from the Swiss Clinical Quality Management Registry, they looked at both the adjusted and unadjusted incident rate of ratio of the cardiovascular events that can occur in rheumatoid arthritis, axial spondyloarthritis, and psoriatic arthritis. And though the unadjusted rates were higher in rheumatoid arthritis, when you adjust out the risk factors and thinking about age, which in axial spondyloarthritis is going to be a significant confounder and may make axial spondyloarthritis look more protective, you see actually very similar adjusted rate ratios of these cardiovascular events. As we think about vascular mortality in axial spondyloarthritis, this is from the Ontario population data, where you can see that the adjusted hazard of mortality from vascular disease and events was significantly higher compared to the non-axial spondyloarthritis controls. However, when you stratify by men and women, you see that this is most significant in men, and in fact, in women, it crosses the confidence interval of 1. In a subpopulation of these patients where medication data were available, as you might expect, statins were associated with a lower association with mortality. However, interestingly, NSAID use was also associated with a lower adjusted hazard of vascular mortality that was not seen in COX-2 selective inhibitors, but more broadly in NSAIDs. Now, thinking more about statins, this is from the British Thin dataset, where they looked at the association with mortality in ankylosing spondylitis over 5 years of follow-up, and showed within AS patients, statin users or initiators compared to non-initiators had a significantly lower risk of mortality compared to those that did not initiate statins, and this was after propensity score adjustment, so really thinking about trying to address confounding by indication in this population, suggesting that statin use may be quite important in patients with axial spondyloarthritis, especially when adjusting for those other risk factors. The aortic root is fascinating to think about in valvular disease in axial spondyloarthritis because the aortic root is thought to be an enthesis. And so when you look at the aortic root, in a mouse model in particular, you see the same resident lymphocytes that secrete IL-17A and IL-22 on IL-23 binding as you do in other enthesial areas. And it's thought that inflammation then leads to a dilated aortic root and aortic insufficiency. Past older studies showed a significant association with AI and even lone AI in patients with spondyloarthritis and in association with B27. And the question is that a true association, or is there some publication bias here or selection bias as you study these small populations of patients? Conduction disease has also been associated with axial spondyloarthritis in big epidemiologic studies, population registries, and then in smaller studies. And the question is, despite this association, including complete heart block and lower degrees of AV block in addition to atrial fibrillation, should we be screening these patients to risk stratify them for this cardiovascular outcome? To look at the association of valvular heart disease and conduction disease in ankylosing spondylitis, Michael Ward used the Medicare data set and published this in the Journal of American Heart Association and showed that patients with AS did have a slightly higher adjusted odds of having valvular heart disease and, in fact, aortic valve repair, not mitral valve repair, interestingly, but that risk was small compared to the general population. In addition, when he looked at pacemaker implantation, again, that prevalence range from 1 to 7.6% significantly increased as you went up in age, and you could see each of these colors represent a different age category. However, when compared to the relative risk of the general population, that risk is relatively flat. And so the recommendation in terms of screening for these both valvular and conduction disease in adults with ankylosing spondylitis and axial spondyloarthritis is that we strongly recommend against screening, in other words, patients that don't have symptoms for conduction defects with electrocardiograms or transthoracic echoes for valvular disease unless they have symptoms. As we think about medication effects on cardiovascular outcomes or risk factors in this case, we studied the effect of NSAID use, particularly continuous high-dose use, in ankylosing spondylitis, and noted in our SOAS cohort that in patients that did not have a prior history of hypertension, there was a significant association with the incidence of hypertension in patients that were using high-dose or continuous NSAIDs compared to those using on-demand or no use. However, the hazard ratio was significant but small, with about a 12-point increase in the risk of developing incident hypertension in high-dose NSAID users. A recent meta-analysis looking at the impact of NSAIDs and TNF inhibitors on cardiovascular endpoints in axial spondyloarthritis, with most of the data deriving from NSAID exposure, showed no harm from these agents on cardiovascular endpoints, and in fact potentially some benefit from NSAIDs on overall cardiovascular endpoints. If you look at the sub-endpoints with ischemic heart disease and acute coronary syndrome, you see that there's no association with benefit or harm on NSAID exposure. However, when you look at stroke as an endpoint, what you see is that there does appear to be benefit, and that is particularly associated with COX-2 selective inhibitors over non-selective NSAIDs. In summary, cardiovascular risk factors are common in axial spondyloarthritis, though manifestations are rare, though studies are limited. Strong evidence to screen patients for cardiovascular disease as you would in other inflammatory arthritis, except for manifestations like valvular disease and conduction disease unless there are symptoms. Medications have minimal to no effect on the risk factors, and NSAID should be used in caution in patients with cardiovascular disease, with really longer-term studies on biologics on these cardiovascular endpoints needed.
Those of you who participated in previous seminars may be expecting a repeat of question 1 and 2 now. We decided to do it slightly differently this time, and so the post-test questions will be bundled after all the presentations. So here is pre-question number 3. Which of the following is a typical feature of the uveitis associated with ankylosing spondylitis? Sudden onset without prodrome, bilateral disease, discharge and crusting, or a small pupil on exam? And please select your answer. 5, 4, 3, 2, 1. Okay, next slide. And this is question number 4. What is the likelihood that a patient who is HLA-B27 with unilateral acute anterior uveitis has spondyloarthritis? Is it 5%, 20%, 50%, or 80%? Please select your answer. 5, 4, 3, 2, 1.
Okay, pues so we are going on now with the presentation by Professor Jim Rosenbaum on uveitis.
My name is Jim Rosenbaum, and I have the honor of telling you about the most important extraarticular manifestation of spondyloarthritis, namely uveitis, although I confess that I have a slight bias that the eye is the most important organ in the body. I've given myself an agenda. I'm going to try to define uveitis. I'll tell you what the prototype is for uveitis in association with ankylosing spondylitis. Then I'll show you how uveitis differs in psoriatic arthritis compared to ankylosing spondylitis. And I'll briefly talk about the biologics that are effective for uveitis. This is a cartoon of the eye. The eye is 2.5 centimeters from front to back. The front is modified skin. The back is neurologic tissue. Some people say an extension of the brain. I like to say that the brain is an extension of the eye. The uvea is shown here in purple. So the anterior uvea is the iris. Then there's the ciliary body and the choroid, which is sandwiched between the sclera and the retina. Now, any part of the uveal tract could be inflamed. So subsets of uveitis include iritis or anterior uveitis, iridocyclitis when the ciliary body is also inflamed, choroiditis, and then when the choroid's inflamed, adjacent tissue is often inflamed. So you have chorioretinitis or retinochoroiditis, a vitritis or intermediate uveitis if the inflammation is centered here behind the lens. And when all aspects of the uvea are inflamed, we call it a pan-uveitis. Now, we've recognized since 1973 that there's an association between HLA-B27 and acute anterior uveitis, as depicted here with a unilateral red eye and a pupil that's smaller because the ciliary body muscles are in spasm. Even though we've recognized this association for 48 years, we still don't really know the mechanism that accounts for the association. What we do know is that in Europe and North America, spondyloarthritis is easily the most common systemic disease associated with uveitis. Now, these data that I'm going to share with you next came from a Spanish study that represented a collaboration between rheumatologists and ophthalmologists. It was called the Sentinel Study, and it was published in 2016, I believe. In this study, nearly 800 individuals with acute anterior uveitis were enrolled. And the very first question asked of these individuals was, do you have known spondyloarthritis? If the answer was yes, the individuals were excluded. And while I've discussed this with the authors, they couldn't tell me exactly how many people were excluded. But you can see of those with acute anterior uveitis, the majority, 475, are HLA-B27 positive, and the authors concluded that 71% of those had axial spondyloarthritis and 21.9% had peripheral spondyloarthritis. I also asked the authors how many had both, and they couldn't tell me, but I think it's a reasonable estimate to say that about 80% of individuals who are HLA-B27 positive with acute anterior uveitis have an associated spondyloarthritis, and there are a number of other studies that support that conclusion. Maybe a bit more surprising was that they also included over 300 people with recurrent anterior uveitis who were HLA-B27 negative. Now, to be B27 negative in this study, you had to have more than one episode of anterior uveitis. But even in these B27 negative individuals, they concluded that nearly 20% had associated axial spondyloarthritis and 11% had peripheral spondyloarthritis. So there's a close connection between acute anterior uveitis and spondyloarthropathy. We can ask the converse. If you have ankylosing spondylitis, what's your risk of developing acute anterior uveitis? I think the best data related to this were published in 2015 in Arthritis and Rheumatology. It was a study about the genetics of acute anterior uveitis and ankylosing spondylitis. And the study concluded that there were genes that specifically predisposed to uveitis without predisposing to ankylosing spondylitis. But this study included a huge number of patients. And a variable duration of illness, up to 50 plus years. And as you can see, when you capture individuals who have had spondyloarthritis for 40 years or more than half report having had at least one episode of acute anterior uveitis. So the characteristics of HLA-B27 associated acute anterior uveitis are incredibly consistent, and I'll actually show you some data to support this conclusion in a moment. But almost always, the inflammation is in the front of the eye, so it's an anterior uveitis predominantly. Patients who have recurrent episodes, and recurrence is the rule, they tend to know when the recurrence is about to occur, just as a patient with a migraine knows of a prodrome. So they will be able to tell you that inflammation is on its way even before you can see that inflammation with a slit lamp examination. The ophthalmologist would describe the inflammation as non-granulomatous, and that's a description usually based on the cells that deposit on the back of the cornea. These are called chorotic precipitates. The inflammation is self-limited in general. It goes away within several days to several months at the most. It only affects one eye at a time, but when it recurs, it might recur in the opposite eye, but again, only one eye will be active at a time. The pressure tends to go down, and that's important because herpes simplex causes a recurrent anterior uveitis with the pressure going up. And there are complications such as posterior synechii, fibrin, and something called hypopyon. This is hypopyon-associated uveitis, pus in the anterior chamber. It was a subject of a report from the University of Southern California 30 years ago. I was taught in medical school that hypopyon-associated uveitis is almost always Behçet's, but in Los Angeles, they found that 80% of the hypopyon-associated uveitis that was not due to an infection was HLA-B27 related. In a paper that my colleagues and I wrote more than 20 years ago, we compared the uveitis associated with spondyloarthritis in purple with the uveitis associated with inflammatory bowel disease. Spondyloarthritis in this instance refers to ankylosing spondylitis or axiospondyloarthritis. And what you can see is that rarely was this inflammation bilateral, whereas with inflammatory bowel disease, Crohn's or ulcerative colitis, almost 2/3 of the time it was bilateral. It tended instead with ankylosing spondylitis to affect one eye, or it could flip-flop, as I said, recur in the contralateral eye, but not be active in both eyes. Whereas there was a minority of patients with Crohn's or ulcerative colitis who had that flip-flopping pattern or that unilateral pattern. And HLA-B27 was associated with nearly 90% of the ankylosing spondylitis patients who had uveitis, where it was around 50% of the Crohn's disease patients who had uveitis. I'm going to show you similar data for psoriatic arthritis in just a moment. This is a recent publication that used a meta-analysis to ask the question, is psoriasis or psoriatic arthritis associated with uveitis? And what they found, combining data from various studies, is that yes, psoriasis does have a relative risk of about 1.5 for increasing the likelihood of uveitis, and the confidence interval does not cross 1. With psoriatic arthritis, the risk of uveitis is higher. And if you flip it around, if you have uveitis, you have an increased likelihood of developing psoriasis. And among patients with uveitis, there is an increased risk of finding psoriatic arthritis. So 21 years ago, my colleagues and I performed a study on the uveitis associated with psoriatic arthritis that was very much like our study on inflammatory bowel disease and ankylosing spondylitis. And interestingly, psoriatic arthritis and inflammatory bowel disease were basically indistinguishable in terms of the patterns of uveitis. So with ankylosing spondylitis, the uveitis starts suddenly. It's almost never insidious, but sometimes it is insidious with psoriatic arthritis. I showed you earlier that it is not bilateral, at least not simultaneously bilateral, but that's common in psoriatic arthritis. I said that the uveitis was self-limited, whereas a chronic uveitis occurs in psoriatic arthritis. I told you that it's usually anterior and rarely posterior to the lens, but it's quite common in psoriatic arthritis to have inflammation that is in the vitreous humor or posterior to the lens. And finally, when it comes to therapy, the therapy really depends on the location. Is it anterior, posterior, panuveitis? And it depends on the severity. So I fit the punishment to the crime. Ophthalmologists generally treat non-infectious uveitis with corticosteroid drops and then oral corticosteroids, sometimes corticosteroid injections into or around the eye. And if those fail, an antimetabolite is a good choice. Methotrexate is probably the most common choice. In terms of biologics, at least in the United States, adalimumab is the only FDA-approved biologic to treat non-infectious intermediate posterior panuveitis in adults. And the FDA has also approved adalimumab to treat any form of uveitis in children. IL-17 antagonists, of course, are very effective for psoriasis. They were trialed in 3 randomized controlled studies for various forms of uveitis, and none of those studies reached the primary endpoint. However, a subsequent study used IV secukinumab at a higher dosage and did report some encouraging results. Still, this is not an FDA-approved indication for secukinumab. So in conclusion, uveitis is the most common clinically apparent association of ankylosing spondylitis that's non-articular. And 80% of patients with HLA-B27 associated acute anterior uveitis have some form of spondyloarthritis. Uveitis is associated with psoriasis and psoriatic arthritis, but the association is much stronger with ankylosing spondylitis. And the clinical presentation in association with psoriasis or psoriatic arthritis is much more diverse than the clinical presentation with ankylosing spondylitis. Thank you for the opportunity to share this information.
Thank you. Excellent. Now for the questions.
Yeah, so here's our last question. In the interest of time, we only have one more. So pre-question number 5. Which of the following statements about the human microbiome is correct? The human body is inhabited by about 10 trillion microbes, which is about equal to the number of body cells. About 500 to 1,000 species of bacteria live in the human gut. Firmicutes and proteobacteria are the most common phyla in the intestine, or inter-individual differences between healthy human subjects are minimal. Please select the best answer. 5, 4, 3, 2, 1.
Quite interesting. Now we are going to see Professor Tachi's presentation.
Ladies and gentlemen, dear colleagues, I'm very pleased to share with you my presentation about the role of microbiome in psoriasis, psoriatic arthritis, and also spondyloarthritis. The human microbiome is the aggregate of all microbiomes which live within a certain region. Today, I'm focusing on the microbiome of the gut and also the microbiome of the skin. Once we are looking how many microorganisms do we host, as a human, we have 10 trillion cells. But how many cells which are driven from microorganisms do we host? 100 trillion cells. So sometimes we are asking ourselves, are we more bacterium than human, since the number is 10 times higher than that what we have as a human. We are learning also that the microbiome has a diversity. The microbiome diversity in the stool is not as high as, for example, on the skin. As you can see also in the tongue, for example, it's more, and also the metabolic pathways are very crucial. Sometimes we are learning more about the filler, For example, that we have 500 to 1,000 bacteria species who live in the human gut, but they do belong to only few phyla, Firmicutes, which are also in the skin, and Bacteroides, which are also more commonly on the gut, but also others are present in the gut. We have learned more about the microbiome in a recent 5 years, about the fecal microbiota transplantation as a novel treatment option, and the gastroenterologist has the first one using this in their daily practice. Once the first results come, it was very encouraging. We have in some reports clinical improvement of 92%, in some of them 0. And we all somehow confused what should believe, what is true and what is not. Today we know there are some diseases which are caused by Clostridium difficile. This is responding to 90% if the patient do the fecal microbiota transplantation. In UC, improvement is also not bad, 30 to 40%, but in Crohn's disease is even less. And what are the ways to do the transplantation? One way you don't want to know, and the other way, transcolonoscopic, is not also easy one, but it's probably manageable. Nasoduodenal, not the best one. I think the oral capsules could be, but is not used as frequently as the others. The question is, what is the hotspot today? The intestinal microbiome is becoming the hotspot. The gut microbiota is playing a very crucial role. In the past 5 years, there have been so many publications that gut microbiota is leading not only to the inflammatory bowel disease, but is having also access to the brain, access to the immune system, access to the non-alcoholic fatty liver, to arthritis, to the insulin resistance, etc. And of course, you will hear a lot of publication where this diet, that diet, this improves the gut microbiota. And also, you might read that composition of intestinal microbiota is associated with many diseases. Just recently, it was presented and published in Science, melanoma and also microbiome. So microbiome is involved everywhere. Atherosclerosis, non-alcoholic fatty liver, rheumatoid arthritis, autoimmune diseases. Wow, so many different diseases. And how it starts? It usually starts with a leaky gut. What is the meaning of the leaky gut? Leaky gut means that this is a normal symbiotic intestinal microbiota. And usually the healthy epithelial cells are producing, for example, no TNF or IL-23 or IL-1 beta. But in the case that we have dysbiosis of microbiota, this is leading to the different way, the opposite way. So inflamed epithelial cells is activating Th17 and they are producing in the opposite way the TNF, IL-23 and IL-1 beta. And the pattern recognition receptors, these are activated in the skin. These are activated in the joints, and we have the psoriasis and the psoriatic arthritis. The leaky gut, what does this mean? If you look carefully, for example, in psoriasis and psoriatic arthritis, it is not intestinal dysbiosis caused only by the food. It is also caused by what kind of the pets we have, what kind of the meals we are taking, what kind of the activities we are doing. So it's very complex. However, it depends if it's going in this direction or toward the increased production of trimethylamine. And trimethylamine, which is a part of the metabolism, this may penetrate to the leaky gut, and this leak on the gut is leading to the accumulation of TMA, trimethylamine, which in the liver is metabolized to a product which goes TMO, oxidized, and this is pro-atherogenic. This is the way how we are understanding that what we eat, the activities that we are doing according to the intestinal dysbiosis. This is also the way how we are explaining in a part, for example, atherosclerosis in patients with psoriasis and psoriatic arthritis. At the other side, the other way is also the activation of the naive T cells, which is happening by the certain bacteria. They may penetrate, they may activate, and they will inhibit the activation of the regular T cells, which will stop the activity of the naive T cells and promote them toward of Th17 effector cells. Is there any association of psoriasis with the gut? Yes. The leaky gut is leading to the activation of toll-like receptors. We mentioned the non-alcoholic fatty liver, the leaky brain-blood barrier is also leading to more depression because of the cytokines which are interfering with depression. But in the skin, IL-17 especially is increasing the inflammation in psoriasis, which at the other side is increasing the leaky gut. And this is leading toward a more severe disease of the leaky gut. And this is leading also to more depression and more systemic inflammation. We have this association of psoriasis with the brain-skin axis, brain and gut axis, but also gut-skin axis. This also to exist. So we are learning that inflammation on the skin is leading to inflammation in the gut, and the gut at the opposite side, the gut is leading to the brain and depression. There is a very good understanding today of depression caused mainly by the inflammation and axis gut, brain, skin. What about the other diseases, like for example, spondyloarthritis? There are a lot of theories, and it looks like that at the very early beginning, the dysbiosis, the gut microbiome, may play an important role. You might see that antimicrobial peptides, like defensine, for example, are also important, and the production of cytokines like IL-13, 23, 17, and also the others may lead to improvement, or in case of Th17, like for example IL-23 and also IL-17 cells, this may lead to the more inflammation. And inflammation in the gut, all the cytokines, TNF-alpha, IL-17, IL-23, and this may go in the circulation and have a systemic effect. This is in a part at least explaining at the beginning early spondyloarthritis. The question which is come, are the bacteria or are probably the fungal infection? From the group of McGonigal, they are trying to show that fungal infection is leading toward the CART9 activation, NF-kappa B, ARC kinases, and pro-inflammatory cytokine secretion. Probably bacteria are not playing such an important role in a spondyloarthritis. In the past, it was thought that spondyloarthritis is very much linked with bacteria, but today, not. And if we carefully look to this one, axial spondyloarthritis is very frequently associated also with Crohn's disease. But whatever, even if it's associated with Crohn's disease, if you do the microbiome, there is no big difference. There's a minimal evidence of gut dysbiosis in axial spondyloarthritis. Independently, if you are looking to the classes or you are looking to the family. Even if you go to the families, you don't see a big difference because the diversity is higher in axSpA than in health control, much higher than in Crohn's disease, and even similar if the patient have Crohn's disease and also axSpA. So in psoriasis, there is a link. In psoriatic arthritis, there is a link, but not in axSpA. There is not so much difference in this direction. Is microbiome in the gut also important for drug metabolism? Yes. So it's not only which kind of microbiome do we have, but also what kind of the dietary compounds is in the intestinum, which drugs and which environmental chemicals are there. For example, if you have an active drug and due to the microbiome, it could be inactive. You might have a prodrug and through the microbiome is changing active drug. Or for example, you have interference and the bioavailability is changed because of the microorganism which are in the gut. And this is reality. For example, if you look on the sulfasalazine, if you see the sulfasalazine in the gut, is leading to the active compound. If you take the methotrexate, it's a biotransformation. We don't know how it's happening, but we know that in the gut, it might be an inactive metabolite, which is leading to the lower bioavailability of the methotrexate. And this is dependent by the biotransformation of the drug into active and inactive metabolites due to the gut intestinum and bacteria are there. And the other part is, for example, of a diclofenac. So the biotransformation is leading to the compounds which are toxic. So today, gut microbiome is playing an important role, not only as a leaky gut in activation of the inflammatory diseases, but also on the drug metabolism and also the physiology in general. We are learning also in psoriasis, once we are looking on pathophysiology, that also microorganisms are playing a very important role. From the books, it is known if you have psoriasis in small children, you are looking to the tonsil if they have a tonsillitis. This was known association. Patients, especially children, have a gutata psoriasis, which is leading to the more severe disease and the first exacerbation of the disease. And today we know it's not only the tonsillitis caused by streptococci, it is also the microbiome in the pharynx which is changed, and it is a dysbiosis on the pharynx which is also making it possible that streptococci and even staphylococci are leading to more frequent tonsillitis. This is the pharynx control. As more the diversity is, it is better for general for protecting us. But if the diversity is lower, then we have a problem. Then the probability that pathogenic bacteria will come is even higher. So today we are asking ourselves, do skin microbiota trigger psoriasis? It's everything about intestinal microbiota, gut microbiota, or it's the skin microbiota. Dermatologists would think skin microbiota. And the presence of 17 and 23, and especially of 17, is leading toward psoriasis, and presence of 23 in the absence of 17 is leading to the Crohn's disease. Psoriasis is not an immune disease. We have some explanation today why it acts like autoimmune one, but it's not one. So microbiome in the skin is much more complicated. Performing skin microbiome, it is like a method to the madness. You have to select properly your patient. We need to have a swab from a certain area, and then all the analyses are very complicated. However, this is very promising. It is also promising because if you take the scalp of the patient, control have a different microbiome. If you take the scalp of the patient, non-lesional one, you see, oh, there is an increase of staphylococci and also on Corynebacterium. But if you look on the lesional skin, then it's a lot of staphylococci, a lot of Corynebacterium, less patient with Propionibacterium. So we are understanding that what is in the scalp important is not important on elbow. But some of these phyla are very important, and especially once we are looking at a staphylococci and Corynebacterium seems to have and to play a very important role in the skin of the patient with psoriasis. Learning more, we are going toward the role of microbiome in psoriasis, moving from the description to a treatment selection. And it could be that in the very near future, we're looking carefully which treatment are we using and how the treatment that we are using, for example, TNF, 17 and 23, is changing the potential microbiome. Is this reality today? We can say yes. There are at least 10 skin diseases where the microbiome and dysbiosis and skin condition are playing a very important role. And among of that, high abundance, especially for staphylococci and streptococci in patients with psoriasis, seems to be of the particular importance. Moving toward of that, what is important? It's the microbiome or the probably antimicrobial peptides like catalycidine. Catalycidine together with DNA, this is leading as an antigen to the activation of dendritic cells and may lead to more production of Th17 cells. Antimicrobial peptides like catalycidine may attract the polymorphonuclear cells, and maybe also that what is attracting the inflammation in the skin, like Kugo's pastel and the other sides, is also leading as a chemoattractant that we have more neutrophils in the skin. So the question is, it's a microbiome or this other antimicrobial peptide? And the third question that we are asking ourselves are probably bacterial metabolites or dietary components which are having an effect. For example, if you take, let's say, vitamin D, this suppresses inflammation in IBD. Something in the skin, not reported. Of course, it's reported. The vitamin D is having a positive effect also in psoriasis. If you look, for example, on gluten, this is leading to the celiac disease, but it may have also important on the skin rashes. So we are learning it's important, bacterial metabolism, but also dietary components are very crucial. Coming to the end of my talk, today we are changing our thought. In the past, the contact with the environment should be avoided. The contact with microorganisms was prohibited. And today, even if you look on the Nature publication, it's called puppy power. Once anathema, now seems to be the dirty environment can enrich the microbiome and can protect sometime from some diseases, or at the other side may cause other diseases. So with this, I would like to thank you very much for your attention.
Okay, before we get to our question and answer session, let's run through the questions again quickly. So here's the first one. Which of the following statements about cardiovascular disease in psoriasis and psoriatic arthritis is correct? Genome-wide association studies have shown that psoriasis and psoriatic arthritis share multiple risk loci with metabolic syndrome and coronary artery disease. Increased insulin sensitivity of vascular endothelial cells may contribute to CVD risk in patients with psoriatic disease. The Framingham risk score underestimates the risk for cardiovascular disease in patients with PSA. Or EULAR recommends cardiovascular disease risk assessment for patients with inflammatory rheumatic diseases, including PSA, at diagnosis and every 10 years. So please select your answer. 5, 4, 3, 2, 1. Excellent. So the majority picked option number 3, and that is the correct answer. So the Framingham risk score underestimates the risk for CVD in patients with psoriatic arthritis. You will have noticed that there is some truth in the other answer options here as well, but turned upside down. So there is no association with GWAS risk loci between psoriatic disease and cardiovascular disease risk, and it is actually reduced insulin or increased insulin resistance that may contribute to the cardiovascular disease risk in psoriatic disease. Let's go to question number 2. Aortic valve disease and conduction defects are well-recognized complications in ankylosing spondylitis. What is the most appropriate screening approach for these conditions in patients with axial spondyloarthritis and AS? Screen all AS patients after 10 years of disease. Screen all AS patients who have more than 2 cardiovascular disease risk factors. Screen all AS patients who had more than 5 years of disease without being on biologic therapy, or mandatory screening is not recommended. Please select the best answer. 5, 4, 3, 2, 1. Okay, so the correct answer is number 4. Mandatory screening is not recommended. And I think Leanne Gensler explained the reasoning here very well. Even though this is a well-recognized complication and comorbidity of AS, the frequency is quite low, and therefore mandatory screening is not recommended. Question number 3, next slide. Which of the following is a typical feature of the uveitis associated with ankylosing spondylitis? Sudden onset without prodrome, bilateral disease, discharge and crusting, or a small pupil on exam? Please select your answer. 5, 4, 3, 2, 1. The correct answer here is number 4, a small pupil on exam. And I admit that this is a bit of a trick question, because the typical uveitis in AS is an acute uveitis, so associated with sudden onset. But the emphasis here was on sudden onset without prodrome. And Jim Rosenbaum had two teaching points in his presentation. One is that the uveitis in AS is typically associated with a prodrome, so patients feel it coming on. And then he made the point that because of spasm of the iris, this pupil is typically small on exam. Question number 4. What is the likelihood that a patient who has HLA-B27 with unilateral acute anterior uveitis has spondyloarthritis? Is it 5%, 20%, 50%, or 80%? 5, 4, 3, 2, 1. I don't think I have anything to say here, so this is the correct answer. Let's go to question number 5. Which of the following statements about the human microbiome is correct? The human body is inhabited by about 10 trillion microbes, equal to the number of body cells. About 500 to 1,000 species of bacteria live in the human gut. Firmicutes and proteobacteria are the most common phyla in the intestine, or inter-individual differences between healthy subjects are minimal. Please select the best answer. 5, 4, 3, 2, 1. And the majority of you picked the correct answer, which is number 2. So we learned in the presentation that the number of bacteria actually outnumbers the number of human cells by about 10-fold. So it would be 100 trillion microbes and not 10. And it's firmicutes and Bacteroidetes that are the most common phyla in the intestine. And I think with that, we'll go to the Q&A session, and maybe we can start with a discussion of what the most important organ is in spondyloarthritis and psoriatic disease, whether it's the eye, the heart, or the intestine.
Who's for the eye?
I think it's the heart.
Yeah, I also think so. I had one question, but I'm not aware if we will be able to answer that, because my feeling is that the epioscleritis or minor forms of anterior uveitis are fairly commonplace, even more than real, let's say, full-fledged uveitis. And I'm also convinced that uveitis can appear as a paradoxical reaction during treatment with anti-TNF alpha agents. Which is your take in that respect? So have you seen patients with uveitis ever developing on patients under anti-TNF alpha treatment, for instance? I know none of you are ophthalmologists, of course, but you know.
I can probably say that we have a problem if somebody is having uveitis, because TNF is the only one which really good response. This is our main problem. And I think the problem is not probably uveitis as it, but patient may have correctoconjunctivitis, may have other diseases. You may switch from one disease to other one. But paradoxal reaction, I'm not aware of that at that intensity that they may aggravate the use of TNF in my patient. I'm so happy if I have a uveitis and I can treat with TNF, because everything else is a little bit. I'm, as I mentioned, not ophthalmologist, but from a rheumatologist, I have learned, uveitis is not easy to manage.
No.
Lai, what do you think?
So I think we have seen patients very, very rarely on an anti-TNF developing uveitis. But then I guess sometimes it's the etanercept rather than the monoclonal. So I guess the most important point is to make sure these patients are actually on a monoclonal, like adalimumab, rather than the etanercept.
So it's insufficient efficacy rather than paradoxical reaction. That's highly interesting. And there's a topic you did not cover in your presentation, Diamond, but perhaps many listeners will be willing to know what's your take on the inflammatory bowel disease appearing in patients under treatment for psoriasis or psoriatic arthritis or spondyloarthropathies. Is there any increased risk depending on which disease we are treating? Of course, we know about IL-17, but can you please enlighten us in that respect?
Of course. IL-17 is playing an important role in the gut, it's for sure, also in inflammatory bowel diseases. And this was also the reason why the studies have been performed in this population. So in general, it was that the patient did not respond better than the placebo, but they also did not aggravate. But if you have today treatment with the IL-17s, we see in the patient who had already an IBD in the past, even inactive, they may have reactivation. There is no new onset of the IBD. And the question is how it's coming, because IL-17 itself is involved there. The question is probably mainly due to the antimicrobial peptides. We do think that IL-17 is producing different antimicrobial peptides, which are making like a sterile part, which is protecting the gut from the leaky gut. And if you don't have a lot of antimicrobial peptide in this area, which is making the contact or with the environment, let's say, protecting us from this contact, it could be this is the leaky part of the mucosa, which is allowing that we have in the gut direct contact, and then we have, let's say, in the place where we have a leaky gut, also the occurrence of inflammatory bowel disease. So it's going more through the antimicrobial peptides, less through the change on the skin microbiome. But this is, like a speculation, and this is something that we think that also genetic background is playing a very important role, and the previous presence of the disease. So there is a link, IL-17 and gut, and there's a link, antimicrobial peptides and IL-17.
So we shall be checking on that sheriff paper you mentioned in your presentation. Thank you very much.
We have a question in the chat here about the role of dietary recommendations, in particular recommendations for a gluten-free diet in patients with psoriasis. Can you comment on that?
Oh, there were so many different diet recommendations. So I'm also teaching at our institute where we are talking about the dietary nutrition. What should you do? You can't imagine how much is recommended. However, gluten sensitivity is more frequent in patients with psoriasis. And it's the psoriasis patient have more leaky gut than the, say, other patients with other diseases. What we have seen that if you don't have a fiber-rich meal, let's say, if the bacteria have nothing to eat, so they will attack the skin and the mucosa. So it means, what do we eat? How we are making our bacteria somehow involved with that what we are eating is preventing the direct contact that the mucosa is part of their nutrition. So our nutrition is helping us to protect also the mucosa from the direct contact with the microbiome. So it is something that we are talking to our colleagues, and what we see that depends which kind of the meal the patient are taking. If they have a very high caloric one with, let's say, hydrocarbons, we see that this is promoting more bacteria. More bacteria, they need more something to eat, and if they don't have a fiber, then they attack mucosa and they attack the gut. So there is a direct correlation to this. In the past, if you would ask me, I will tell you it's rubbish, it's nothing, you can eat everything. Now, I am slightly changing, because working with nutritionists, they have been able to convince me that, for example, if you live in Barcelona and you have a Mediterranean diet, this is the best. But if you live in Barcelona, it's not mandatory, but also in Germany, if you avoid sausages and have Mediterranean diet, is even better than if you have something different. So I think it's difficult. It's not one diet. It is more complex than we think.
Yeah, I think there's a real need for research in this field. Because I get in the clinical practice, I get more frequently asked about dietary advice for patients with axSpA, for instance, than about advice for what kind of exercises to do.
Exactly.
And I think in terms of research, we know more about, even though it's not such a lot, but we know more about the role of physical therapy than about diet.
Yeah, definitely.
I have one question for Dr. Tam. So,
Yes.
ultrasound devices to check for the carotid arteries or the femoral arteries are not so easy to come by. But so perhaps for the standard practicing dermatology of rheumatologists, it might make sense to prescribe statins for all the patients coming in. What's your take?
So this is a very good question. See, there is actually no clinical data on, the role of, just prescribing statin. But then, it's actually very difficult to see an effect. For example, there is actually a study prescribing, an RCT prescribing a statin to a non-selective group of rheumatoid arthritis patients. And this is actually a very large size study, but they failed to demonstrate any, efficacy. I think there are a number of reasons. Because with better treatment, then the cardiovascular event rate, for example, in rheumatoid is getting less. And then we are not selecting a high-risk patient, then that's even more difficult to demonstrate the effect. So that's why I think at least probably we should try to select the high-risk group by doing a cardiovascular risk score. So if the risk score is high, so I guess no doubt that this patient would benefit with a statin. But we're talking about, the gray zone area here. For example, if the score is just low or intermediate, especially for the intermediate group, I think in those group, it would be, more easier for us to tell whether they are beneficial if we can have some more imaging. We've been doing that for the last 10 years. With an expertise, this is actually requiring like 30 minutes, up to an hour. So it's actually very, it's non-invasive, and it would not induce any discomfort. So I think this is worth a try.
Excellent.
Can you comment on the role of NSAIDs and in axSpA? I'm very surprised by what we heard in the presentation about the effect of NSAIDs on the cardiovascular disease risk in this population. Are these data real, or what do you think?
Yeah, again, this is a very good question. So if we look at the meta-analysis published a few years back, looking at all the patients, including osteoarthritis and other inflammatory disease patients, you can see very clearly that NSAID is definitely a risk factor. But then, if you look in more detail, actually, this study may be biased by rofecoxib, so it's been taken out from the market. So after removing rofecoxib, if we look at patients with inflammatory arthritis, so removing the osteoarthritis patients, just looking at inflammatory arthritis patients, including rheumatoid arthritis and ankylosing spondylitis, actually we're seeing more and more data suggesting that exposure to NSAID is not associated with increased risk. On the other hand, it may actually decrease the cardiovascular risk, especially in patients with ankylosing spondylitis. So my impression is that these could be real, but then we have to be very careful. So for patients without established cardiovascular disease or not at high risk of cardiovascular disease, then the use of NSAID may be beneficial in terms of damping down the inflammation, which otherwise may drive the atherosclerosis. And we also recently looked at our patients, and these are PSA patients. There's actually not much data on this. And also, we have found that actually the use of NSAIDs in patients with psoriatic arthritis was associated with a lower risk of cardiovascular event. So I think this definitely deserves more study, and hopefully we can do it in a large-scale prospective randomized trial. But I don't know who's going to do it.
Excellent. Thank you very much. If there's any burning question, I would like to discuss that. If not, I think it's close to, okay, well, Just one question about the concentration of HDL. Should we measure HDL just before putting our patients on statins?
Again, this is a very good question. So I think the point is, when do we measure the lipid level is we need to measure it at least 3 months after the disease has been controlled. So the question is whether we should monitor HDL. I think, we do routinely monitor the HDL as well as the LDL, because sometimes after treatment, the total cholesterol level may go up. But actually, if you look at the fraction, both HDL and LDL may go up. So actually, the atherogenic index may not change. So I think this ratio is actually more informative than just measuring the total cholesterol level.
Okay, thank you very much. I think it's about time we calling this meeting to a close. I'd like to thank the speakers on the discussions and also, of course, the content creators and the patient partners. And I'd like to thank the audience for putting in your questions. You have been very interactive. Thank you. I'd also like to thank Nucleus for technical support and also Lisa and Janine and Spartan and Grappa for putting this thing together. And if you wish to join in Spartan or Grappa, please look on the websites and think about the presentations you have seen today and others that have already taken place will be available on the Grappa or the Spartan website in due course. And there will be a survey coming along. Please complete that as to give us a bit of feedback. And again, I would like to thank Pfizer again for providing their support to this activity. And I'd like to remind you that there are some upcoming seminars which you can see on the screen now. That's on global perspectives, new therapies in development, and another one in June in hot topics, race, age, and sex considerations. Once again, thank you very much, and hope you have a good day and a good week. Thank you.